Dear Chairman, colleagues and friends, it's a great pleasure for me to be with you today and to talk about pulmonary embolism and what is to be done in diagnostics and in therapy. It's very easy to recognize if we have a pulmonary embolism CT, but before we are often not so sure. This was a 73-year-old patient, and he had just a syncope and a little nausea, and afterwards it turned out to be pulmonary embolism. This, however, is a very old case. 30 years ago I did that, and this was very massive. You see the black lung here, and you see the completely occluded pulmonary artery, and you can also see it in the X-ray. This is not so difficult to think of the diagnosis, but we have some problems with the not so open cases. What to say about epidemiology? The annual incidence in these countries here is going up, but on the other side, and that is lucky and makes us happy, that the hospital lethality is going down. That means we have some more care and some good therapies and diagnostics. A problem is that pulmonary embolism is like a chameleon. It can change color and symptoms and signs, and it's very often undiscovered, as our German cardiac newspaper shows here. We know some strong risk factors, and I'm sure you all know them, but there are some which have been added, which we did not know so long before. And this is hospitalization for heart failure and for atrial fibrillation and flutter. Within the last month may, however, be only this outstanding a high risk factor, or myocardial infarction also. And we have to take care of these risk factors. With regard to symptoms, the problem is that the clinical signs are not always as indicative as we would like it. This is a story about 2,000 people which had confirmed pulmonary embolism, and this is non-confirmed. And all of them, this total group was suspected to have pulmonary embolism. And what you see is there is no difference in dyspnea. There is no difference that is significant with chest pain. There is no difference with cough. So we have some problems. We always say normally the symptoms are the most important things, and we have to recognize that it's not like this in pulmonary embolism. It can be very misleading. What I also find interesting is that we have some new information, or relatively new at least, that many of these patients come with syncope as first symptom. You can read here, in 1 out of 6 patients who come to the emergency room with pulmonary embolism, they have the only sign of syncope in the beginning. And I think that is very interesting, and we have to take care of. The low probability or not so high probability, we have also to use scoring systems. If we don't have complete indicative signs or symptoms, we need scorings. And the WELL score is very well suited to go into that. You know these symptoms here, clinical signs of deep venous thrombosis, and so on, immobilization. And then you get a scoring, and at least in our hospitals here, we use the scoring systems if we have a not clearly detected pulmonary embolism or suspicion of that. The next is to go into the risk calculation. If we think or know and say, yes, this may be pulmonary embolism, we have to orientate what is most risk for the patient and who is not in so high risk. And the highest risk you can ever have is hemodynamic instability, and some parameters I will explain to you in a moment. Right ventricular dysfunction and troponin elevated. Intermediate is then, that means the patient is hemodynamically stable and has all the other symptoms that are summarized in the score. And here only one of them positive. And of course, if you don't have all of that, you are normally in low risk. This severity index is a little bit more specifying. It's called SPECI score. It's H, high H, history of cancer, cardiopulmonary disease, and tachycardia, high blood pressure, and low blood oxygen saturation. If this is present, this is higher risk, of course. How should we go into diagnosis for pulmonary embolism? These green fields, these summarize very high recommendation, first-class recommendation. If there is hemodynamic instability, then the next way will be to do a CT or a bedside echocardiogram. And it's also of crucial importance very early to start with anticoagulation, because this had been shown to be the very decisive parameter for survival. So anticoagulation is the first, and the risk to do it, and it's not necessary, is lower than the risk not to do it, and it's pulmonary embolism. Then the criteria, you saw the scores just before, and here once again anticoagulation. And then we have to go on in our diagnostic strategy. And once again, we see here a prediction rule that is, like you saw, the Wells score. The D dimers, they are very often thought to be very and completely exclusive, 100% if they are negative. That is not the case. It's 95% of negative prediction or 98%, and you should keep that in mind. The scintigraphy is, of course, very valid, but it's not present in normal hospital everyday life. And so it's not so important in clinical use, I think. Very important is, if you don't have CT angiography especially, to do the ultrasound of the lower limb to see for thrombosis. MR has no place in the diagnostics of pulmonary embolism. So what to do? Please follow the red dots I brought in this graphic. If you have a diagnostic algorithm for high risk, you know, the first question is, you found this patient is hemodynamically unstable. This is the first question, stable or unstable. And then the next question is, do I have a CT immediately or don't? If no, then you have to treat like high risk. And if yes, you should do it and you get a clear-cut image. You saw that in my first patient examples at the beginning. If the patient is more stable, that means without hemodynamic instability, then you can first do, if you have a high clinical probability, it's again CT. So you see stable or unstable, CT, or you don't have a CT. If you don't, then the dimers, it's especially if you have low or intermediate probability from the clinical point of view, is the best thing to do. Afterwards, what do we do? How go we go on? The first is anticoagulation. I already told you the decisive moment and aspect whether the patient will survive or not is do you do early anticoagulation? And this is the most important. And then if you have high risk, intermediate risk, and low risk, you have different ways to go on. If you have high risk, it's reperfusion treatment, maybe with hemodynamic support. We have ECMO cases, a number rising now for treatment of pulmonary embolism. If it's intermediate, then you could do another troponin test. In any case, this means hospitalization. And if it's low risk, it's a patient for early discharge. And if there are no other reasons, maybe you could make your choice to discharge relatively early. How is the reperfusion therapy? The thrombolytic therapy, when hemodynamic problems appear, is number one indication, and you should do that. And you should also do the anticoagulation without any delay, also already during the workup progress. And if you do that, you should start with low molecular heparin or fondaparin NOx, and this is for most patients. And the patient who is suitable for NOACs, you should start very early. And if you have patients with vitamin K dependent anticoagulation, the range to be chosen is 2.5 at best. The recommendation for doing afterwards, the anticoagulation is for more than 3 months, recommended in all patients with pulmonary embolism. And the discontinuation is in those patients who have very high risk factors for bleeding, but normally it's longer. And to extend it is if there are patients with additional risk factors, you can see here. Follow-up is very important. There have to be concepts. The treatment does not end with dismission from hospital, but this is a long treatment and follow-up, and you have to establish algorithms in your hospital to take care of that. One exception for the NOACs, they are completely not recommended during pregnancy. This is very important. what are the controversies and what is the future? My last two slides. First of all, we have to face a very high rate of relapsed venous thromboembolism and pulmonary embolism after the discontinuation of the anticoagulation. You see here, recurrence of deep venous thrombosis, 36%, and recurrent pulmonary embolism, 11%. So we will have to take care of the underlying mechanism. This is very important. Was there a sufficient explanation of what happened or not? Is cancer one of the diseases of the patient? Because that is very important for follow-up. And the questions for the future, how can we optimize the using of the D-dimers and the testing algorithms in certain subgroups of patients, previous history of pulmonary embolism, pregnant women. And the next is, what do we do with those patients who have pulmonary embolism subsegmental, that means very peripheral, and how can we exactly estimate the long-term risk and the long-term treatment options. This is a very short presentation, I hope interesting for you, about pulmonary embolism, and this is the German word for thank you. It was my pleasure to be with you and give this lecture. I am ready to answer your questions in the discussion.
Thank you very much, Professor Budde, for this excellent presentation. And I see that Professor Ming have a question to you.
Following your presentation, I think there is many new information. I would like to know how about the roles of Bồ Sang Tong. This is a new one, normally associated with PE5, prostaglandin to inhibitor to reduce the pulmonary pulmonary hypertension for prevention of pulmonary embolism. How can we use this drugs for prevention?
I think that is a useful concept, and it's on the long run, it's not so pronounced in the guidelines up to now, but I think it is a very good concept. Yes.
Yeah. Dr. Lợi,
Yes, I have a question for Professor Thomas Budde. For patients after pulmonary embolism, but there is still the deep venous thrombosis. So how long the anticoagulation should be continued? And how about the role of NOAC?
Yeah, first of all, it's very important how extended this thrombosis is and whether there is a good development. If there is regression, then it would be useful to continue and to follow up again with ultrasound. Normally, I would say 6 months, but it depends also whether there has been venous thrombosis in the past before, or it's a relapse of thromboembolism, pulmonary embolism. But if the thrombosis is going backwards and you see it's fine, then maybe you can do that at the time longer because it may disappear completely. And you have to watch it, and you have to have the compression socks and so on. So it's, in a way, it's an individual decision, but those people who still have thrombosis, I would say at least 6 months. If it's relapse, it's longer.
And how about the role of the intracaval venous umbrella to prevent the pulmonary embolism?
Yeah, that is very interesting. I don't know, maybe you see it. If I hold it up, this, what you see here, is such an umbrella. Yes. You see that?
Yes.
Yes. This was in a pregnant woman some 30 years ago. I implanted that. And it was the only way because there were some bleeding problems also. And then I took it off afterwards, and the woman, there were siblings, they came to the world and everything was fine. And this was her present. She said, keep it. you can use it. It's not so very often, but in special situations you can do that. But you have to think of it. If you put it in, it will do what it is designed for. It will collect thrombus. And you have to be clear what is the strategy to take it out and to take out the thrombus it collected. Surgery is possible, but not so nice, especially in this situation. There are other techniques now, or there's local lysis. It's not so frequently, and it's in the guidelines, but it's not the first line.
Thank you.
My pleasure.
Okay, I have a question. Hi, Professor Budde. In Germany, you have the patient COVID-19 with the PE and the treatment different with any other diseases? Please.
Yeah. First of all, the treatment of pulmonary embolism, it's quite the same because we don't have any differential strategies first. But on the other hand, you have to keep in mind all the other manifestations of COVID-19. In our city here, the university hospital, at the time, they had 150 COVID patients at ICUs in one hospital here. So big experience. And there are some pulmonary embolisms, but they are treated like without COVID because we don't have any experience whether there is a special therapy. My next door neighbor, he is 50 years old, and he is always asking whether he can help me in the garden and so on. And he got vaccination, and he got afterwards he got pulmonary embolism. It's a phenomenon that is existent. Yeah.
Yeah. In Germany, maybe now the people has a vaccination total.
Not total. In our city, which is Essen, we have some 500,000 people, and the rate of people who have vaccinations, both vaccinations, and are at least 6 weeks after it, is about 55% at the moment.
Thank you.
It's my pleasure. Thank you so much.
In Vietnam, I have a question. In Vietnam, some information outside the hospital said that we can use some new anticoagulant, NOACs, for prevention of the PE in case of COVID-19 complication. Is this right or no? Can we use NOACs?
I think there are no prospective trials yet, but this is what we would do if there would be pulmonary embolism or deep thrombosis. This is the only we have at the moment. There is no clear concept that is differentiated to the factor that is COVID and pulmonary embolism. In Germany, we have about 3 to 4 groups with high numbers of COVID patients and post-COVID patients. Post-COVID patients, 250 and so on. We are just gaining experience. It's the same with atrial fibrillation. It's interesting that up to 10% of the people with COVID have rhythm disturbances afterwards. But it's at the moment, there is no prospective trial. It's just cases. But I would guess it's useful to do it. This is the only thing you have in your hands.
We have a question from the audience. In which patients should we use the thrombosis analysis therapy? Thrombosis from the audience.
Thrombolysis, yeah. Thrombolysis is suited especially for patients. You saw the first branch of the decision tree. Is the patient stable or is he unstable? And if it's unstable, then it's reperfusion. If you have any technique to do reperfusion just with anticoagulation, let's say suction or anything, or thrombus fragmentation, and everything is fine, then you can stay with anticoagulation. But if the patient is unstable and you don't have any other means, it's immediately, there's a class 1. These were the green lights in my slides. It's a patient for thrombolysis very soon. And if you are in a situation where he's first stable and he is deteriorating and is getting worse and then unstable, this is rescue thrombolysis, and it's a very clear-cut indication also.
Okay. Are there any more questions? So thank you very much, Professor Budde, for the very important disease of pulmonary embolism. And in all of time, we want to go forward.